The title I was given was General Practice, GPs and Oral Health. It's quite a broad topic, but I'm going to focus a bit on complex chronic illness and multimobility and the issues of health inequity as I go. As Ruth said, I've been a GP at North Richmond since '94. And as you're probably aware, we see the population that the health centre services is a relatively socioeconomically disadvantaged group of people with complex multimobility. Is quite common. So I'm going to be drawing on that. I'm also as Ruth said, I'm a research fellow at the Department of General Practice, where most of my research has been in chronic illness, particularly diabetes, but I'm not going to talk about diabetes. I can reassure you because I know you've had lots on diabetes. And the other interest I've had has been in this area of health inequity. So I'm going to be drawing on both those backgrounds in my talk. Okay. So the 4 points I'm going to make, I'm going to talk about general practice and oral health from a simple clinical perspective, or one view of that. Perhaps I'm going to say how your average GP maybe sees the issue of oral health. Then I'm going to move into this discussion around chronic condition care and how that shapes the work of GPs. In particular, that may influence how they interact with oral health services, I think, and some of the policy responses we've seen and some of the unintended consequences of those. And then I'm going to move on to this issue of more complex multimobility and health equity, and look at some of the local innovations that we've been really lucky enough to be part of here in North Richmond, and see what we can learn from those in terms of, going forward, I suppose, or scaling up or implementing those more widely. Look, if this is a list of topics from searching the GP's journal, the Australian Family Physician, over the last 10 years. You look at it for topics related to oral health or dental care, and these are the sorts of things that turn up, I suppose. So this is what GPs see coming across their desk, what they think oral health issues are all about. So it's about managing dental trauma and infections, obviously sharing or collaborating to some degree, I suppose, with dentists around issues of warfarin management, around extraction, and getting that wrong most of the time, I think. Xerostomia is a common issue. Well, certainly it's discussed in the journal. The biphosphonate issue, I'm sure you're familiar with that. Managing oral health conditions in people with schizophrenia, sleep apnea, and diabetes. So these were the topics that came up. Not a lot. Some of these we do well, some you've heard about a little bit already, and some perhaps we could do a bit better at. I was then wanted to point out that oral health does in fact make it into the Royal Australian College of GP's preventive care guidelines. So that's encouraging, that's very good. So it's given its own focus there. And really, so you can see there, these are clinical guidelines for preventive activities around oral health. And GPs are encouraged to do two things opportunistically, that's the second point here, where people have conditions that place them at risk, they're smokers or they have a known xerostomia, that they should be opportunistically examining them in the oral cavity. Obviously, that's the recommendation that's made. And for people at higher risk, low socioeconomic, as Wong mentioned, Aboriginal Torres Strait Islander, elderly and refugee communities, the recommendation is that the GP undertakes a 12-monthly oral examination and education. So there's very little there about referral or integration of care, I think. It's simply recommendations that the GP undertake these sort of preventive oral health activities. So there is an interest in health equity already coming out in that preventive care guideline, I think. Okay, but look, that's a simple sort of clinical sort of view of the issue. For a long time, there's been a high-level understanding that oral health is a key issue in the rising epidemic of chronic conditions in Australia, and I'm sure Georg has talked about that earlier today. So back in 2001, this report from the Commonwealth, Chronic Diseases and Associated Risk Factors in Australia, pointed out that in fact dental care is in fact the most prevalent chronic condition, and that's certainly not high in the thinking of GPs as they manage what they think is the tsunami of chronic illness that they're sort of having to deal with. And it's the second most commonly occurring health condition ever in Australia, apparently, after upper respiratory tract infections, and with all the consequences that I'm sure you're familiar with and you've heard about. So, there was this high-level recognition that oral health is an important, a very, very important part of the whole chronic condition paradigm that we're all now working within, I think. Okay, so that's good. That's encouraging. So just a bit of history, and again, I'm not teaching you anything you don't already know. But just to revisit the issue that back in '84, when these eminent men over here established Medicare after a sort of long and checkered history preceding that dentistry and allied health services were completely excluded from that payment system, of course. And there's a long professional and political sort of background to that. I'm sure you're aware of that. But in the context of that emerging interest in chronic illness, there were attempts starting from the early 2000s to change the way general practice worked, and at the same time to integrate general practice work with oral healthcare. So again, you're probably familiar, the Enhanced Primary Care Program, which established a system of payments basically to incentivise GPs to spend longer times with patients and undertake case management. Initially, didn't have a strong link to allied health and other health practitioners, but then eventually included the capacity to refer patients who had a care plan under this program to allied health practitioners and to dentists, but there was a very low level of rebate available, I think, to the dental services at that point. And this major reform in leading up into 2007, I think, and you possibly know the details better than me, but there was this significant increase in the cap and the amount of money made available through this program for integrating patients who'd seen a GP and had a chronic condition management plan and then could access dental services through that. So the cap being set at over 4,000 over 2 years, and as you know, there was an explosion in the amount of money spent within that program. So in 2009, apparently, nearly 500 million or 430 million was spent nationally on dentistry just within that program. And we heard from Wong what the annual spend on dentistry is. And just as another comparison, just last year, the spend on general practice services was 6.8 billion. But so 430 million, so a lot of money was spent. And that obviously prompted some reconsideration of the program and was brought to an end, as you know, in 2012. And in more recent times, there's been more residual sort of programs linking people with state-based services. The costs of that program exploded, and there's some sense that a lot of that money possibly was being spent not where it was best targeted, perhaps, that there was some inequity in the way that money was being spent, that it was some of it was going on cosmetic work or not really targeting the population groups that perhaps it should. So there's an issue of equity there, I think. But this was an interesting graph, I thought, from a paper in the Australian Journal of Primary Health just a couple of years ago, showing that if you separate out the proportion of that work that's actually been spent on preventive dentistry, that actually compares quite favourably to what was being spent within that enhanced primary care sort of program on physiotherapy, podiatry, dietetics. It's quite similar. So what is that? That's 35 million out of the 430 million. So it's a small proportion, but it compares quite favourably. So, that's interesting. I guess it's a sense that if you get the targeting right and the incentives right, maybe you can still make some headway through a program like that. In that sort of context, I suppose I wanted now to turn to this issue of inequity, and I'll show you why, I'll tell you why, but I just want to define health inequity as unjust and avoidable differences in health status or healthcare experience, I say as well, between different population groups. And this is a particular issue in relation to this epidemic of chronic illness that we're now working within. Here's an example of health inequity. You heard about diabetes today. So this is self-reported prevalence of diabetes, which varies like 4 times from the leafy eastern suburbs to some of the more disadvantaged parts of Melbourne. So 13% versus 3%. And look, some of that might be due to different sort of ethnic mixes and different genetic predispositions amongst communities in those areas, but quite a lot of that difference, I think you'll find, will be due to different exposures to social determinants of health, such as healthy food, public green space, opportunities for physical activity, etc., employment levels, income, educational achievement. So there's a clear sort of inequity in one of the most common chronic conditions we work with. So let me just talk a little bit in more detail around the way this chronic illness epidemic is changing the nature of general practice work and what that might mean for its capacity to integrate with oral health care. So Carl May, who's a sociologist in the UK, has written that chronic illness produces routine and highly structured patterns of professional labour, and that means professional labour for patients and doctors, I think, extending over lifetime illness careers. So that can generate quite bureaucratic management-style relationships between GPs and patients in the setting of this very sort of humdrum, routinized sort of work patterns, where GPs are much more involved in monitoring, surveillance, and accountability for the sort of things that they do, and regulations around guidelines and adherence to protocols and systems of care, that sort of thing. And in the process, patients have become enrolled in this whole sort of chronic disease enterprise, and they're now expected to be very active, in self-management, expert in how they deploy services, and resourceful and thrifty, I would say, and prudent. So these are the sorts of ideas, I suppose, and values that sort of shape some of the work that goes on in general practice these days. And I think it's partly related to some of those policy responses we saw. They sort of fit hand in glove, I think. But in the setting of that sort of changed nature of work, we can see that inequities in the experience of care emerge. So, for example, GPs in the most disadvantaged areas are 40% less likely to spend long consultation times with their patients. Patients in disadvantaged areas are more likely to receive prescriptions, but they receive significantly fewer investigations and referrals. Patients from disadvantaged areas receive less participatory consulting sort of styles. They get less information, less partnership building dialogue from their doctors. So in the end, I suppose you could say that a very integrated form of comprehensive care, care plus, if you want to call it, becomes the privilege of a small sector of the sort of relatively well-off, health literate advantage sector of the population. And it's contextualised by some of these changing natures of work and some of the policy responses that go on. There are, of course, as you're aware, oral health inequities paralleling those we see in chronic conditions, general practice. So these are some data from the 2015 report that you can see there. I'm sure you're familiar with that. So 2 to 3 times rates of decayed, missing of filled teeth, periodontal disease, toothache, and social discomfort associated with low household income. And similar inequities, I suppose, or differences in the access to care measures, rates of dental visits, and higher rates of avoiding or delaying dental visits. So social gradients exist in dental care as well, whether they're subject to the same sorts of paradigm shifts going on in general practice care, I'm not sure. I think these are particularly driven by financial barriers as much as the changing nature of work. But there may be some linkages there, I think. So just this last one on health inequity. Most people with chronic conditions don't just have one, they have two or more, they have multiple chronic conditions, otherwise known as multimobility, especially as you get older. So this data is from a study in Glasgow by Stuart Mercer, Bruce Guthrie and others, published in The Lancet. And it looks at the rates of multimobility, having two or more chronic conditions, by age and by socioeconomic status of the suburb that you live in. So you can see that at any level of multimobility, people from the most disadvantaged suburbs achieve that sort of level of multimobility 10 to 15 years earlier than people in the most advantaged suburbs. And the other important thing from this that they found was that these people in this middle-aged group, so middle-aged adults presenting with multimobility, the most common form of multimobility, complex illness burden, is mixed physical and mental morbidity. So comorbid psychological, psychiatric issues and physical illness as well, which really sort of leads on to my reflections. This is the last section of my talk on my work here as a GP. So I'm going to really talk about some of the local issues around working with communities and patients who are involved in illicit drug use who have mental health problems. And I know you had a conference on that last year, but I won't spend a lot of time on that. Combined with social disadvantage. And what are the links between that sort of population group and that sort of work, contextualised by the sort of changes I've talked about, and oral health issues. So it's a complex sort of interface, I think. So, but certainly you'd be aware that the oral health status and oral health quality of life in people who inject drugs is worse, and there's a cyclical arrangement, I think, between some of the causes and the predisposing factors there, which can be pharmacological, biological, psychological or social, and the effects of that, which can sort of become a vicious sort of circle. Interestingly, within that population with worse oral health and oral health quality of life, there are socioeconomic gradients even within that community. So worse oral health and quality of life is associated with lower incomes and lower education, and some gender differences as well. And finally, interesting for me, because I am involved in a lot of methadone prescribing, that people on methadone therapy in this survey, which is from the Journal of Public Health Dentistry in 2015, it's an Australian sample, people in methadone therapy had worse oral health. And certainly my patients say that the methadone is bad for their oral health, but I see it as really as a missed opportunity for really engaging people in comprehensive primary health care via the methadone program into general practice and into oral health. But we'll talk about that in a minute. And if you look at mental health, people with serious mental illness, the issues are very similar. So in people with serious mental illness, such as schizophrenia and bipolar disorder, first off, they are more commonly diagnosed with lots of physical health problems, and it's a little known fact that people with serious mental illness die, in fact, 25 years earlier than the general population, particularly from cardiovascular disease, so that's an often ignored inequity. But they have, over 3 times the risk of complete tooth loss. They have much poor oral health. Okay, I'm about to finish. Okay. So I guess my point was that, and finally, this is a quote from a nurse working in primary care around how people with serious mental illness who are well linked in with general practice did better, potentially. So that there are opportunities, I think. And certainly the population group I deal with, these things commonly coexist: serious mental illness and use of illicit drugs. So I do want to highlight these benefits that we've been lucky enough to be a part of here. I call it co-location plus. So we work in this wonderful facility. We work with a very innovative dental health, oral health program upstairs. And these are some of the things that I get from that. I certainly get enhanced professional relationships and opportunities for sharing case discussions or discussions around issues of general physical health, social disadvantage, working with that complex group that I do. There's enhanced on-the-day access upstairs, so I'm able to take a patient upstairs and talk to the reception and say this patient is in pain, or they really need to be assessed something today. So that's a terrific, and you can imagine how difficult that is for a GP out in the community who just doesn't have this sort of access. How can we scale that up? There has been a small program piloted here with one of the dental hygienists, formalising input into those GP management plans that I talked about, to try and get dental assessment embedded in that. And finally, there was a program which is currently not existing, I think, of enhanced access on Friday afternoons, dropping in for people who had injecting drug use and oral health problems. So these are small local innovations that reduce the burden of work and the burden of treatment for patients themselves, and create a system that is minimally disruptive to their care. So, as Ruth's hitting me on the back here, I think the keys to taking some of these things forward are, we don't have to have professionally divergent paths. Martin and I trained together in Adelaide University many, many decades ago. And we actually were a part of the community health movement, and there was some multidisciplinary education going on at an undergraduate level, so that was terrific. I think it's no mistake, it's no coincidence that we're discussing this in a community health centre, informed by important value systems which have their origins in Alma Ata, Ottawa Charter. They're very, very important, and they shape the sort of useful, innovative local solutions that are got greater potential, I think, than some of those unintended, top-down, system-based sort of reforms that we saw. So I think that's food for thought, and I'm finished now. Thank you very much.